Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. It is now my pleasure to turn the conference over to today's first presenter, Chris Hund. Please go ahead.
Thanks, Stephanie. Hi, everybody. This is Chris Hund, Director with the Center for Health Innovation at the American Hospital Association and Director of the AHA's Team Training Work. Welcome to the monthly team training webinar here in March 2019. Today's topic is regular or extra crispy, lessons from the field in addressing burnout. So we're really excited to have this presentation today. Just a few rules of engagement for you. The audio for the webinar can be accessed in two different ways. You can listen through your phone, and if you do that, please mute your computer speakers so you don't have any sort of weird feedback. Or you could listen straight from your computer, and that's great, especially if you have a solid internet connection. We're going to do a Q&A session at the end of the presentation. So we really encourage you throughout the presentation to chat questions in the little chat box you see on the right-hand side of your screen. We'll try to answer some as we go along, especially if they're more logistical in nature, and if they're more for the presenter, I'll gather them up and try to curate a nice question and answer period at the end. Anything that we don't get to, we'll try to get back out to you in written format after the presentation. Just a few things to tell you about before we get going, some upcoming team training events. Registration for our Team Steps Master Training courses in 2019 is now open. You can go over to our course schedule to learn more and register. The spring ones are actually already filling up quite a bit, so if you're interested in taking a Team Steps Master Training course at one of our regional training centers around the country, head on over to the website. That hyperlink is live, actually, and should open up a different window on your browser. We'd also like to announce something new and exciting that we've created. We have something called Team Steps Next Steps. And what this helps you become what we're calling a Team Steps influencer in your organization. It's going to be a day-and-a-half immersive workshop where we really dive in deeper on implementation planning using design-centered thinking, processes, and ways of doing things. So this is really to help you get unstuck. This is really to help you amplify the successes you've had. So whether you're really doing great and you want to amplify and spread and grow, or if you're experiencing some challenges and you need help getting unstuck, that's what this is for. So we are doing this. Our first time out of this is going to actually be a pre-conference session at our national conference in San Antonio. So you could head over to this link to learn more about how you become a Team Steps influencer and register. So this is really the next step past being a master trainer. We also have our next monthly webinar announced for April 10th. It's creating a culture of safety in 4 not-so-easy steps. So you could register for that now. And then finally, we have our national conference. So early bird registration for this is done at the end of this month. So to save a little extra money, head on over and register now. It's in San Antonio, June 12th through the 14th, but we have a few pre-conference workshops as well. We have the aforementioned Team Steps Next Steps, June 11th and 12th. We have a Team Steps Master Training course, if you're interested in doing that, also June 11th and 12th. And then on the morning of the 12th, we have four-hour sessions, 3 different ones. So we have one on driving change, one on fostering resilience, and one on various Team Steps immersive games and activities. We've done this one at the conference before, but not as a pre-conference section, so it goes into that a little bit deeper if you're familiar with our work with gaming. Conference is always a lot of fun. It's really built by the community, for the community. A lot of people that come to this conference to present are people that have come through our workshops, come through the conference before, so it's really a community-driven initiative, and it's a lot of fun. Great place to learn and also to network. So come over and see us in San Antonio at the start of June. Our contact information, you could always check in on us on the web at aha.org/teamtraining. You can email us at teamtraining@aha.org. We try to get back to you within a day or quicker, or give us a call at our phone number, which is here on the screen. All right, so without any further ado, I'd like to introduce Elisa Arespacochaga, who is VP here at the American Hospital Association with AHA's Physician Alliance. Very excited to have Elisa on this webinar. She presents nationally and on all kinds of topics around physician burnout and resiliency and workforce, and so I think she's going to bring a really cool perspective to our work here today. So Elisa, I'm turning it over to you.
Thanks, Chris. Really appreciate the opportunity to join your group. I'm a big fan of the work that you guys do at Team Training, so I'm glad to be able to share some of the work that I have been doing at the association as well. As Chris mentioned, I'm Vice President of the AHA's Physician Alliance, so while some of the comments I'm about to make will sort of be colored by a physician lens, they do apply to everybody, and I will probably say that a number of times throughout this. So here's quickly what I'm going to cover, talk a little bit about where we are in the country related to burnout and well-being, a little bit of the causes and where things came from, although I know most people are well aware. I'm going to talk about some organizations that really are looking at systemic change and how to make that happen, and then some ideas of how to bring these lessons home to your own organization. So we'll start with a little bit of a visual image. I know this is an image that probably strikes the fear into most people. I was flying home yesterday and realized as I got to the airport my phone was at about 5%, and I thought, I literally will not be able to board a plane, would not be able to get home until I charge my phone. So I think many of us spend a large part of our day worried about being in the red. So I'm going to talk a little bit about some of this and how we deal with it. So a little bit of a quiz here. I'm going to go through these quickly since obviously you can't quite raise your hand on the phone. But think about, for yourself, for your team, for your family, in the past week, how many times have you skipped a meal or eaten a poorly balanced meal? And if it came from a vending machine, it's a poorly balanced meal, just to define that for you. Worked an entire shift without any breaks, changed plans because of work, arrived home late from work, felt frustrated by technology, used a mouse maybe more forcefully than it was meant to be used. This one is not actually a thing. You cannot drink too much coffee. I'm evidence of that. But or slept less than 5 hours a night. And if you said, yes, I've slept less than 5 hours a night, you're in good company, because about 40% of Americans sleep less than 5 hours a night. They're also 1.7 times more likely to die of all causes than those who sleep more than 5 hours a night. And I do need to give credit to Brian Sexton for this list and the one that follows, because I first heard him use a version of this. So, if you're doing all of those things, are you burned out? Well, you're trying to be everything to everybody. Maybe you don't feel like you're making a difference, or the work you're doing isn't recognized, or you're having trouble balancing between work and personal life. This is my favorite. Your job varies between monotony and chaos. This is one that I'll come back to, drives a lot of burnout, is you don't feel like you have control over your work. And then, to add to the humor, you're burned out if you work in healthcare. So I put this up not for the statistic, but for the date. It's a little small. If you can read it on the article byline. This article was in the New York Times in 2012. So 7 years ago in August, there was a big expose about how there's this huge problem for physician burnout, and we really need to be paying attention to this. And 7 years later, I think we all agree that there's a problem about burnout. It's not just among physicians, but that we haven't necessarily landed on exactly what the solution is, in part because I don't think there's one solution. There are a lot of solutions because burnout relates to culture. We know it's a problem. We know it affects patient safety, patient satisfaction, huge corollary with turnover and the costs involved in replacing team members, overall costs. And actually there's a study out of Stanford that isn't on this slide where they were able to correlate recovery times for their patients with physicians who answered on surveys that they were more burned out or had more of the symptoms of burnout. And those patients took, on average, 10 days longer to recover. So now the level of burnout of your physician could affect how quickly you recover from surgery. So where is this all coming from? As I said, burnout relates a lot to culture. And until you know and understand the culture that you're in, you may not realize exactly what water you're swimming in. You may just think this is the way we do things. This is how it goes. This is what you have to deal with to continue to serve your community and make sure they're healthy. So let's dig a little bit into what that water looks like. To start with, there are really three influencers on burnout. First is personal resilience, and I don't want to discount that. That is very important, but I don't want anyone to walk away from any conversation with me thinking that's the only way to fix it, because meditation is amazing. I'm really bad at yoga, but I understand it's really good for me. But I can tell you that's not going to fix a situation that drives burnout. Those things are very good for your own personal resilience and developing those, but you really need to understand the other two factors as well. In fact, most medical students, when they arrive at medical school, are more personally resilient than the average population. By the time they finish residency and enter practice, they are less resilient than the average population. So there is something about the environment in which you are in that really has an influence on how burned out you are. So there's that second area, which is about the environment you're in, the health system, your immediate practice and system and hospital. And then there's that third, even broader area that's about the regulatory requirements, the culture in which we live, and the expectations on both our healthcare system and our fellow clinicians. Part of that is coming from the fact that healthcare is morphing at a couple of different paces. So while we are in general shifting from that today column on the left to the future column on the right, we're doing it at different paces, at different rates, where some things are moving really fast, some things are lagging behind, and it's making it very hard to keep on either side of the column. So while we're moving from treating individual patients, we're still getting paid largely in many places based on volume, and we're treating illness rather than looking at driving wellness. So I sort of view that future state as maybe you get more of your healthcare at your fitness center, and it's much more coordinated across you have access to all of the different things you need, but that's not how we're set up today. It's not how we pay for care today, and it's not how we provide care today. So while we move little bits of the healthcare system along, we haven't yet moved all of it, which is driving a certain level of dissonance that makes it hard to understand where you need to be and help people, have some control. So when I started in healthcare a number of years ago, this is how I would have described how healthcare works. There is the administrative team that makes sure that the institution is running, that in particular in hospitals, really managing the hospital, making sure all of that is moving forward the way it needs to be. And then there's the clinical team that's really focused on the patient and making sure the patient has what they need and really is getting the care in the most appropriate way. They agreed on that sort of faraway horizon of the vision, mission, the goals of the organization. Everyone was there to treat the patient and get the patient better. And that line of sort of relationships and communication was better in some places, worse in others, but I relate this to sharing like a 4-bedroom house between two people. You could sort of not know that the other person was there for a long time. You could live together and yet not interact without too much friction. Unfortunately, all of those environmental factors, all of those paradigm shifts I mentioned, are pushing us much closer together. We're now sharing a studio apartment, and it makes a difference how you interact with each other. You have to have trust. You have to assume some positive intent and mutual accountability and common goals and open communications, and understand that everyone on the team is there for those same vision, mission, and goals. But that doesn't just happen because you put everybody in the studio apartment. You need to work at it. And I realize I'm preaching a little bit to the choir here because you all know that you need to work at building a team. But that's one of the places where burnout and those frictions really create burnout. The other place that pretty much every physician in the country cites as one of the biggest drivers of burnout is the black hole that is the electronic medical record. I think it's a scapegoat for a lot of deeper cultural issues in some places, but I think it's also legitimately a challenge to ask folks to engage with something that is really not designed for the clinical care they would like to provide. So in one of the case examples I'll cover in a little bit, you'll hear how one organization really looked at how can we make this not a thorn in everyone's side. But to really address all of these big environmental changes and how to understand how we can address burnout in our organizations, we need to head upstream a little, really think about, so where is this coming from? We know that all of healthcare is changing, but we knew all of healthcare was changing when folks were getting into medicine, going to medical school, going to nursing school. Healthcare has been changing. I feel like we are on this sort of 40-year trajectory of major change that seems to be taking a really long time. So what is it that we can do to really get down to how we can fix it? And this is a little bit dated since it only goes through 2014, but this was from a study in Health Affairs looking at those things that drive satisfaction. Again, this is for physicians, but I would argue it applies to almost everyone who works in healthcare. Looking at what it was that drives satisfaction in providing care. And if you look at the various topics on the left-hand side, the only line that's ever so slightly going up is patient relationships. Everything else about medicine isn't a driver or is losing its influence as a driver of satisfaction. The one thing that physicians are holding on to is that relationship with their patient. So let's start there. How can we make that better? And if you go back to the work of Christine Maslach, who coined the term burnout in a paper in 1980, she's a psychologist in California and has written pretty much the seminal works on this issue. She identified 6 areas that really correlate to burnout. So 6 domains of work that really are the identifying factors for burnout. I'm going to cover 3 in a little bit more detail, although they're all important. One that I'd like to point out to folks is the first one there, workload. That's not about necessarily too much work, although that could be the case. It's about not the right kind of work. I have found in many cases that if folks are engaged in what they are doing and are feel like they're connected to purpose and to a calling and to a mission, the amount of work that they are able to accomplish might be significantly above sort of a standard workload, but they don't feel overburdened by it because of these 2 other areas that I'm going to mention, control and community. Having enough control over the resources and the ability to do your work in a way that's effective and efficient and feel like you're making a difference is one of the biggest drivers, in particular among physicians, to really understanding and not having that feeling of burnout. And the second really is about that community. I have talked with many colleagues who are radiologists who are very sad that the tradition of a hospital reading room has gone away, where they could, the room with all the, where they could read the x-rays, because their surgical colleagues used to come down and, they would debate a care plan, they would debate a potential for a surgery, discuss it, and now many of them felt like their only interaction with their colleagues was through their notes in a record, and that was it. There's actually one organization in Madison, Wisconsin, where they rebuilt, if you will, the doctor's lounge for the hospital, but they put it in the middle of town because that's where everyone had an occasion to be and to gather. And they made a deliberate point of creating that space for community. So I would argue, while the other three are also very important, those three seem to, in particular with physicians, drive a lot of the correlation to burnout. So what did those three have in common that I think is really important to highlight? You've all heard cultural eat strategy for lunch or breakfast or some other meal. I think one of the really important things to keep in mind is that unless you have the infrastructure in place in your organization to really make it easy to do the right thing, make it easy to do the thing that you're hoping for, there's basically a big monster lurking out there in the deep, because all the culture in the world, if it takes 20 clicks to do something, and there's a way to do something that's not quite what you should be doing, but close enough that takes 2 clicks, it's going to be really hard to get everyone, even with the best of intentions, to do all 20 clicks every time. So how do you set up that infrastructure? That's another one of the examples I'll talk about, to make sure that you're removing those spots of friction throughout the day to reduce burnout. So now that you guys are probably all thoroughly depressed, I'm going to talk a little bit about some of the positive stories of how some of the organizations around the country have addressed different areas of this, and talk a little bit about the work that's coming out from the AHA's Physician Alliance to help help other organizations address this. And that's about enabling systemic change. So first, as I said earlier, there's not one solution. There are many solutions available, and you will probably need to employ a number of them in your organization. Burnout is not one thing. It is a cultural issue. It's underlying many of your systems and many of the organizations. And you're going to have, if you tamp it down in one place, you're not going to be able to, it's going to pop up somewhere else. So you really need to think about multiple solutions. So for probably everyone on the line, this is not going to look very surprising. It's a version of a PDSA cycle. But we are putting together a resilience playbook for hospitals and health systems to really think through how you go about addressing this in your organization. And the basic ideas of it are really understand what the local needs are. I'm sure that in every department in your organization, you can ask folks what it is that the biggest pain points are and identify some areas that you can tackle. So while I encourage folks to do surveys or otherwise focus groups, understand what people are facing, probably the second worst thing you could do is ask people and then not do anything with the results. So definitely do some sort of assessment and talk to the teams, but then relatively quickly moving to understanding what you can do and how you can define an opportunity to address and then test it out. Encourage folks to test in small rapid cycle improvement, and really take those improvements and then start to spread them where they make sense. Again, keeping in mind, one burnout solution, the burnout solution that works in an ICU is not going to be the burnout solution that works on a PEDS floor. There's going to be different nuances to each, but a overarching commitment to move forward is really essential. So, and the last thing that's really important is celebrating some of the successes that you find along the way. I think it's that's one of the ways to really encourage continued involvement. So I'm going to tell you about some of the case examples we've worked with. And all of these case examples are available on our website, which is aha.org/physicians. I'll put it up again later, but there's much more detail in each of the case examples written up. I'm just going to give you some of the highlights. The first one is HCA. You all know HCA, 178 hospitals, 1,800 sites of care across 20 states. They have 3 different EHRs that they use and a huge variation in documentation content. So, and then their nursing engagement surveys indicated that documentation was the leading pain point. It was the biggest challenge everyone faced. So they brought together their chief nursing officers from across the regions to talk about clinical documentation redesign. So first, they went in to figure out what is it that we already do. You know, what documentation do we have that we can take out? What documentation do we have that can be automated? And what can we put in different systems? And they went back to each of their organizations and figured out and talked with their teams and understood, okay, so we inventory patient belongings in the medical record. Does that need to be there? Does it need to be somewhere else? Does it need to be done by the nurse? Let's figure out where that goes. They made sure to remove restrictions of data that didn't need to be restricted between clinicians. And then as often as possible, they figured out ways to automate and auto-populate data so that they could have vital signs not entered by the nurse, you know, as she did her rounds, but that were really, truly real-time and would upload directly from mobile monitors. And then they shifted some of the process improvement work that was happening in the EHR to other systems so that they weren't ending up clogging up that work. And the result was they saved about an hour of time for each nurse on each shift. And they had a really clear idea of how many nurses they needed in each unit, how much time they needed, you know, and how to help each unit best get the education they needed for each of their providers. Now, one of the things I want to highlight here is that they actually took about a year to pilot this to really make sure that they worked out a lot of the bugs along the way, ensured that they had the right education in place, that they were explaining not only what they were doing, but the why behind it, what the philosophy was behind doing these documentation changes, making the policy changes that they needed to. And then once they had implemented in the first 11 hospitals that were that pilot phase, they started to record videos with the people who had been part of the pilot and to get testimonials and start to share those, so that they started to build a little bit of a groundswell of interest in being in the next wave of the pilot and really get people clamoring to be a part of this solution. The next one I'm going to tell you about is at Erlanger Health System. This is in Tennessee, public healthcare system, 6 hospitals and so forth. And they had, they're in Chattanooga, Tennessee, and they were actually looking to implement an EHR without driving burnout. They were trying to figure out how they could really understand, how they could really bring the EHR into their organization without challenging their physicians and really making sure that their clinicians were well supported, had everything they needed to be able to do this, and that it wouldn't be a challenge in their system. So what they started with was, first of all, they brought in 100 additional team members to really be the implementation team for this work, to make sure that things went smoothly. They made sure to make the records more user-friendly. They built templates and used voice recognition software to try to make it easier for the clinicians to minimize clicks and all the typing. Then they also really went through and formatted the charts for readability so that when providers were going in and looking at notes, they would have they worked very closely with their clinical teams to understand what is it that they needed to have on the screen. So if a progress note was up, having the patient assessment and plan immediately viewable while maybe some of the older notes were condensed so that they could work with the record. So it wasn't designed around what was the most useful set of data to be displayed for someone else. It was what was most useful for that clinician in that moment treating that patient. And the interesting thing is they actually had a whole lot of support from their clinical team in moving this forward. They were able to not have any revenue losses amidst the 6 months of EHR implementation, and were able to really prepare ahead of time for all the workflow changes that needed to happen, and had a lot of support across the organization. So this is a more proactive approach to addressing burnout, but one that worked really well, knowing that the EHR implementation would be a challenge in their organization. And then the last one I'm going to cover right here is at the University of Rochester. Now, they have another big system in upstate New York, and they really wanted to bring to their leadership team an understanding of the impact of burnout, not only on physicians and other clinicians and the rest of the team, but really on the patient experience and how that correlation happened. And one of their researchers, psychiatrist at their organization, has done a lot of work looking at the impact of a workplace on executive brain function and the development of burnout, and then how that correlates with the patient experience. And on our website, and I'll tell you about it in a little bit, we actually have some of his links to some of his articles, which if you're interested in this connection, it's really quite fascinating. But what they basically did was really spend some time trying to understand and really use the science to build a case for well-being in their organization and a well-being committee to address the areas where they saw there were challenges. They ran into a number of costs in terms of their employee medical insurance that they were able to reduce. And they really looked at how do you apply human factors and ergonomics to understand how they could make change in their organization to improve clinician well-being, which they are directly linking to improved patient experience. And I'm happy to share that, some of the articles with the team to share with all of you. So now let me talk about some of the resources that are available from AHA. As I mentioned, I lead the AHA's Physician Alliance. So while our work is focused on physicians, there is a lot about this work on burnout that is related to everyone in the healthcare team. So the AHA Physician Alliance is really focused on leadership, lead well, be well, addressing resilience, and care well. And be well is very deliberately in the middle because you cannot lead others, nor can you care for others if you are not well. So all of the resources I mentioned you can get to from that website, aha.org/physicians. And there are a number of other resources that I'll mention now that are on our Be Well page. So first, we have a Knowledge Hub, which is a resource library about building and supporting well-being both personally and professionally in your organization, links to a number of different articles and tools. There are tools to build resilience and all of these case examples I've mentioned, and there are actually 10 of them total. And then some articles regarding the drivers of burnout, and the work that I mentioned earlier from Christina Maslock is all linked there as well. We also have a large series of podcasts and webinars on this issue from plenty of other folks, other case examples of work that folks have done. And those are really largely looking at the organizational improvements. The last area that AHA is really focused on is addressing the regulatory environment that we find ourselves in to ensure that we are not spending time and effort and burning out our teams doing paperwork, doing things that don't help our patients. So this report, which is available on aha.org, was done about 1.5 years ago and really outlines the cost of some of the administrative burden that is out there. And we've been working rather closely, and we've commented on a number of the reports that have come out, including the recent one in January from ONC about how to reduce clinician burden. Our comment letter's up on our website. But there are a couple of key numbers from this report. One is that we spend, as a hospital, $1,200 every time a patient is admitted before anyone touches that patient, in terms of ensuring their coverage, billing, and making sure that we're meeting all of our conditions of participation, and various other regulatory factors that are involved in that patient entering the hospital is a cost of $1,200 before anyone actually provides any care. And the average size hospital has about 15 clinicians on staff who do not actually provide patient care. They address regulatory issues. So those are things where we're working hard on behalf of all the hospitals in the country to ensure that we really are reducing that regulatory and administrative burden to what's appropriate for good patient care. All right, so how do we bring this home? First, I'm going to argue that leadership matters. Whichever leader you identify with on this slide, because they both are leaders and they both have their own leadership styles, you need to understand that things like, there's a survey done at Mayo among 3,000 physicians, and they created a sort of a leadership score, composite of 2 particular questions. I am treated with respect, my leader treats me with respect, and my leader is interested in my opinion. And for every 1 point that was more positive, that composite score, it correlated with a 3% reduction in burnout and a 9% increase in satisfaction. So as a leader, and everyone, I would argue, is a leader in some scope of their lives, you have to understand that how you show up in the room is never a neutral event. When you walk into a meeting, to an office, your presence is either a positive or a negative. It is not a neutral. You have some influence on that room, and how you lead makes a huge difference in the culture of your team, which I'm sure Chris has said many, many times. So I'm going to tell you a little bit about one more case example, and this is one that we've worked really closely with. This is my good friend Tom Janicki at NOVANT Health, who went through his own journey around burnout. And he realized in his busy family practice that, and his hospital and health system responsibilities, he was creating his own perfect storm of burnout. He did a huge amount of work himself, working with a coach, and then brought all of this work to his health system and said, I can't be the only one. And to the credit of the NOVANT health system leaders, they really said, you know what? No, you can't. Let's figure out how we help others. And they developed a program, a leadership development program, that really is about that nexus between leadership and burnout. Created this 3-day intensive program, and they have managed over the last 3 years to take their overall engagement scores among their employees from somewhere in the, I think it was in the 40s originally and up to the 70s. But not only did they do that, the part of this that always, I guess it's 62 to 89%, I should look at my own slide. But the part of this that really gets to me every time is that even for those who did not participate in the program, so their leaders might have gone to the program, but these team members didn't participate in the program themselves. The only change was the impact of the program on their leadership teams. Even for them, their engagement scores jumped dramatically, again, rising nearly 20 points. So that idea that the leadership and the way that people show up in their teams is so important. And I think it's really important to understand that that has made a huge difference, which is one of the reasons that we have partnered with One Team and NOVANT to offer that same 3-day intensive program around the country to different groups. And we have a couple programs coming up. Again, information on our website if you're interested in more details, but we'd love to have folks participate, realizing that not everyone can bring this type of program in for their entire population. So couple things I want to leave you with. First, and this is not going to be a surprise to anyone on this call, you need a team in healthcare. Physicians traditionally have been trained to make decisions quickly with the information available to them, possibly incomplete information, and be solely responsible for their decision making. And that sort of traditional, leader, that tradition isn't what we need in today's healthcare. And I really don't think that's how physicians are being trained anymore, but I think there's a certain idea that they need to be sort of on their own. And the bottom line is that if we're not a team, we're never going to be able to move forward. So I'm a huge Olympics geek. I love the Olympics. I watch like every minute of coverage. This was 2008, and this was the final of the men's relay, the 4x100 relay. So these are arguably the 4 fastest men on the planet. The U.S. has dominated, well, had at the time dominated this event. And the way that you run it, the heats are such that these 4 had not actually run a heat together, but they were the 4 fastest. And yet, one of the most important things you have to be able to do is not just run your 100 meters really, really fast. You have to be able to hand off the baton. And you see the way they are standing, they don't actually look. It is done entirely on feel and practice and protocol. And if they don't practice enough, they're never going to pass the baton effectively. So they dropped the baton, I think this is the 3rd turn, and they lost. But the important part here is that when the world record for one man to run the 400 meters, so the full length of that track is 43 seconds. For the 4-man relay, it's 36 seconds. So the team is always going to be faster, but only if they work as a team. All right, last thing, and this is the audience participation part. So I'm going to see if you can type in the chat box or what you think this number represents. Give you a few minutes, a few seconds to do that. All right, well, I'm going to have to give it up for team training. Every time I do this, I get all sorts of answers, none of which are the number of hours in a week. But the first two answers here are hours in a week. That's awesome. It is, in fact, there are 24 by 7, 168 hours in a week. So I encourage you all to think about, okay, the age of a burned out patient feels at the end of a week is probably one of the better answers I've gotten. Thank you. I encourage you all to think about, so you've got 168 hours coming to you in the next week. What's one thing you can do with one of those hours to either address your own feelings of burnout or to help your organization address burnout? So I challenge you to think about that as I wrap up. All right, so some key takeaways. It's a relatively simple roadmap, but ask the people who are doing the work where the pain is. Start small, test what you want to do, and then iterate and improve and spread it and celebrate it. Second, you need that infrastructure to support a strong culture. So if you've got a great culture, support it, help it grow. And then an effective and efficient team that works as a team is always going to be faster. But then again, you guys all know that. So with that, I am going to wrap up, and I'm happy to answer any questions that you guys might have. And please feel free to reach out to me at any time if you have any questions about anything I covered.
Thanks so much, Elisa. That was really great. I love that Olympic stat that you just used there about the record. I'm definitely going to use that in the future, things that I do. That's awesome. I really love that. So a couple questions that came in before as well when people emailed us questions ahead of time. A lot of people were curious about if AHA or if you have done anything in looking at this outside of the hospital, in primary care, long-term care, et cetera. I kind of think that it might even be perhaps worse because there's less of a safety net around people in small offices or in other situations.
Absolutely. And while we have not done as much, the AMA has actually done a large amount of work. They have an entire course and set of modules on their website which are available to anyone. It's called Steps Forward, and that's linked from our resources. But it is very much a series of tools and resources that go through how smaller offices might address burnout, not only their physicians, but their entire team.
That's great. Yeah, so somebody else was curious about non-physician resources. So the AMA has some things that might be good for other team members too?
They do look at, yes, they have, they basically look largely at the functioning of a small office, so it's all the team members in a small office. And again, as I said, a number of the resources that we have, while some of these pieces are targeted at physicians, there are a number of them that go across every care provider. The other area to look at, which the name of it will not inspire as much confidence of this, but they do in fact have a number of resources for other for the full allied health professional area, is the Stanford the website is WellMD. So they do have a number of resources for physicians, but they also have sections for other professionals in the hospital.
Got it. Sounds good. So a couple questions around, people thinking around the quadruple aim and bringing in the idea of some sort of care for the caregiver or some sort of burnout quality measure. Have you guys been thinking about that, talking about that? Where is that standing? Do you envision that being something that comes in the future?
It certainly has been talked about quite a bit, the idea of creating a measure to understand burnout, and I know there's some work underway to look at that. It is a little bit more challenging to make some of the connections, so it's something we're looking at carefully, but there is certainly some work afoot to really understand how to measure how burnout impacts quality and safety and patient care, and how to tie that into some of those measures. But the other resource that I hadn't mentioned before is the National Academies of Medicine has a collaborative that AHA and many, many other organizations are a part of, looking at clinician well-being, and they also have a resource library which includes I think there are 7 or 8 tools that are out there to measure burnout specifically, including the original Maslow burnout inventory, and they have links to all of them on their website and a little bit of an description of each one and sort of where it came from and how it's used. So I encourage folks to look at the National Academies of Medicine as well.
Thank you. There was a question earlier that I'll take that was just questioning if there are specific team steps tools that could be useful in addressing burnout. And I think that the way to look at that is to think about how Elisa early on had some of the elements, one of them being more, operations leading to burnout, just the way that the infrastructure is set up, I believe, and another being along, personal care is also helpful in stopping burnout. So if you think about team steps tools, thinking about getting into a cycle of briefing, huddling, and debriefing, making sure that you very much support that idea of people cross-monitoring each other and having good situational awareness, I think that helps in a lot of these areas. Not only make a system run better and more efficiently, because there's not a lot of miscommunication, but I also think it helps personally with those issues of resiliency. If you know that you've created a culture where people have each other's backs and that there are backups for you and it's not all relying on you alone, I feel like that has to do a lot to help people feel that they have a little bit more resiliency and a little bit more buoyancy. So I really think a lot of the team steps tools help in those areas. And we're not just talking here, in my opinion, about the tools just helping people feel better, but we're talking about institutionalizing, putting these things in place to really help with all the things we've been talking about. So just wanted to add that real quick. Let's see. Completely
agree. And I would say, going back to the domains of work life that are correlated to burnout, and again, this is Christina Maslow, I believe this was early 2000s. And really this idea that how you help people really see how they have control over their work, how they have control over the situations that they're in.
Yeah.
And feeling that they are part of a bigger community are two of the biggest drivers that I've seen in all the work that I've read about. And then one I didn't highlight specifically, but I think gets to your point, is this idea of values, that the values that the organization espouses are in fact the values that everyone is living in the organization, and that there is a good match between those values and your own values, really is one of the more subtle, if you will, drivers of burnout, to really make those connections that this is I believe in the work that we are doing, would be one of the ways that folks ask that question. I think having some of the tools from Team Steps about really, connecting to purpose, I think help address that issue.
Thank you. Yeah, thanks for putting this slide up. I think that really does help anchor it. So that's good. Yeah, it's really just getting away from doing the wrong kind of work. There's so many things in the Team Steps tools that just help people kind of either get to an answer faster or make sure that they're on the same page and have a shared mental model. That has to take away that kind of emotionally draining work of recommunicating or constantly worrying that people maybe aren't on the same page. So, all right, let's see. So what else do we have? So there's actually a question here about whether or not people use the same survey when they're looking at employee engagement and burnout when we're talking about clinicians versus non-clinicians. So I imagine that even non-clinically, there's high instances of burnout in the healthcare world.
Yep. There is, and it depends on the organization. I have seen both, but in most cases, it is the same. The same issues are faced by clinicians and non-clinicians. And while there may be different solutions, different approaches, depending on whether you're in the clinical space or not, there is an underlying factor here that caring for people is by nature a traumatic profession. So understanding that and making sure that folks have the resources to be able to address that in their work and in their life is important. I know we've done a lot of work with, for example, the Schwartz rounds and some of their ability to help and build that community. So there is certainly a need for that approach for those who are working directly with patients and are with people at what may be the worst times in their life and supporting them. But the overall systemic issues that are driving burnout across healthcare, that is everyone who's everyone who's involved in healthcare.
Thanks, Elisa. I think that's a really good place for us to stop. If we have any other questions, things we haven't asked, things that were very, very specific to certain situations, we'll make sure to follow up with you and get those questions answered. We will have the presentation recording posted very soon, within the next couple days, on the AHA Team Training website, and we will also be sending out an evaluation. It's very helpful for us. We really do practice what we preach. We debrief with all of our speakers, talk about what went well, what could be improved, and those evaluations are so helpful in all of these situations. So thank you all for being with us here today. And Elisa, thank you very much for joining us. It was quite appreciated.
Thank you. It was a lot of fun.
Bye, everybody.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.